Today, we will be talking about a brain disorder that is known by many called schizophrenia. It affects the way a person acts, thinks, and sees the world. People with schizophrenia have a changed insight of reality. They may see or hear things that don't exist, speak in a strange or confusing way, believe that others are trying to harm them, or feel like they're being constantly watched. With such a blurred line between the real and the imaginary, schizophrenia makes it difficult, even frightening, to negotiate the activities of daily life. In response, people with schizophrenia may withdraw from the outside world or act out in confusion and fear.
Schizophrenia symptoms are both negative and positive symptoms. And positive symptoms in schizophrenia reflect an excess or distortion of normal functions. These active abnormal symptoms may include delusions. And negative symptoms, which are the symptoms of schizophrenia that involve functioning below the level of normal behavior.
There are many different types of delusions associated with schizophrenia. Somatic delusions are when an individual feels inappropriate concerns about their body, believing as if they have diseases that they do not actually have. Delusions of grandeur is when an individual exaggerates their importance, thinking that they play an extremely important role in society. Delusions of infidelity is when an individual has false beliefs usually associated with pathological jealousy, occurring usually in situations between spouses. Delusions of thought broadcasting is when an individual believes that other people can hear what they are thinking. Delusions of thought insertion is when an individual believes that outside forces are inserting thoughts into their brain. Reference delusions is when someone believes that other people's behaviors are referring to their own. Persecution delusions is when an individual believes that others are trying to inflict harm on them or their family. Delusions of control is when an individual feels like somebody else is in control of them and is forcing them to do things against their will. Self-blame delusions is when an individual feels remorse without any justification for the feeling, and blames themselves for the events that they had no affiliation to.
These beliefs are not based in reality and usually involve misinterpretations of perception or experience. They are the most common schizophrenic symptoms. Hallucinations involve seeing or hearing things that don't exist. Although hallucinations can be in of any senses, hearing voices is the most common hallucination among people with schizophrenia. Another symptom of schizophrenia is thought disorder. Difficulty speaking and organizing thoughts may result in stopping speech mid-sentence or putting together meaningless words, sometimes known as word salad. Another positive symptom is disorganized behavior. This may show a number of ways ranging from childlike silliness to unpredictable agitation. Some symptoms are loss of interest in everyday activities, appearing to lack emotion, reduced ability to plan or carry out of activities, neglect of personal hygiene, social withdrawal, and loss of motivation. Some behavioral symptoms are dropping out of activities and life in general. Cognitive symptoms associated with schizophrenia involve problems with the thought process. These symptoms may be the most disabling in schizophrenia because they interfere with the ability to perform routine daily tasks. A person with schizophrenia may be born with these symptoms. These symptoms include problems with making sense of information, difficulty paying attention, and memory problems.
Most cases of it appear in the late teens or early adulthood. However, schizophrenia can appear for the first time in middle ages or even later. In rare cases, schizophrenia can even affect young children and teenagers, although the symptoms are slightly different. In general, the earlier schizophrenia develops, the more severe it is. Schizophrenia also tends to be more severe in men than in women.
In order for someone to be diagnosed with schizophrenia, they must meet a series of criteria. Out of the symptoms of delusions, hallucinations, disorganized speech, abnormal psychomotor behavior, and negative symptoms such as avolition, an individual must experience at least 2 of them frequently within a 1-month period. The individual must also experience occupational dysfunction, where their functioning in areas such as work, relationships, and caring for themselves is disturbed below the level that was present before the onset of symptoms. The signs must be continual over a duration of 6 months. There cannot be evidence of other disorders such as bipolar disorder, and the symptoms cannot be because of substance use.
According to the article, cortical thickness in first episode schizophrenia patients and individuals at high familial risk, a cross-sectional comparison, explained how cortical thickness reductions in the brain are associated with schizophrenia, but are unsure to what extent they are driven by genetic factors and whether these factors are present before the illness. In the Edinburgh High Risk Study, there were MRI scans for 150 adolescents at a high risk for schizophrenia. 36 required matched controls and 34 subjects with first episode schizophrenia. Clinical information was researched for 10 years for the control and high-risk groups. During this period of time, 17 high-risk subjects were diagnosed with schizophrenia, roughly 2.5 years after the MRI scan, and 27 subjects experienced subclinical, psychotic, and isolated symptoms. The results of the experiment revealed first episode subjects showed widespread thinning of the cerebral cortex, mostly in the superior, frontal, medial, and lateral regions. In contrast, high-risk subjects showed cortical thickness reductions in the left middle temporal gyrus. No major differences were discovered between high-risk patients who later were diagnosed with schizophrenia and those who did not develop schizophrenia. In conclusion, the results confirmed cortical thickness reductions in patients with schizophrenia. Increased risk of schizophrenia is related to thinning of the left middle temporal lobe. According to an article titled Effect on Parental Age on Treatment Response in Adolescents with Schizophrenia, APA, Advanced Paternal Age, is related with increased risk for schizophrenia, but the effect on treatment response hasn't been studied for a long period of time. Methods used in this experiment were related to the parent's age at the time the child was born and symptom severity and response to treatment in adolescents diagnosed with schizophrenia. Results from the experiment where both paternal and maternal ages showed major effects on treatment response on all paliperidone ER versus placebo. Paternal age was related to the improvement in positive symptoms, and maternal age majorly correlated to negative symptoms. Only paternal age stayed related with the treatment response in analysis with both the parents' ages. In conclusion, APA was related with a larger treatment response to both placebo and paliperidone ER, but not to the age of the initial symptom severity in adolescents diagnosed with schizophrenia. According to the article, reduced habituation in patients with schizophrenia. Neural habituation is the decrease in brain response to repeated stimulation. There is strong evidence for physiological and behavioral habituation deficits in people diagnosed with schizophrenia. Also, a study found lower neural habituation within the hippocampus, but unsure whether neural habituation deficits are limited to the hippocampus and specific to faces. In this study, habituation of different brain regions in schizophrenia was researched using both object and face stimuli. During the fMRI scan, 23 patients diagnosed with schizophrenia and 21 control subjects observed blocks of a repeated neutral face or object. Compared between groups were the primary visual cortex fusiform, face area, and hippocampus. After the scan, memory for word pairs, and faces were assessed. The results of the experiment were patients showed lower habituation to faces in the primary visual cortex and hippocampus, but not the FFA. The healthy control subject showed a pattern of hippocampal discrimination that between different and repeated images of both objects and faces, a patient diagnosed with schizophrenia did not. Hippocampal discrimination was absolute associated with memory for word pairs. In conclusion, patients diagnosed with schizophrenia showed lower habituation of the visual cortex and hippocampus and an absence of neural discrimination between new and old images in the hippocampus. Memory performance associated with hippocampal discrimination, implying lower habituation, might have to do with the memory deficits widely observed in schizophrenia.
Antipsychotics are one of the primary treatment methods for people with schizophrenia. These medications help reduce the amount and intensity of the psychotic symptoms a person experiences. There are also programs that are available to people with schizophrenia. The assertive community treatment is where a team of medical and psychological professionals reach out to clients in their everyday lives. Throughout a person's lifetime, they may experience several courses of symptoms. The periods in which a person's symptoms no longer interfere with their behaviors are what clinicians call remission. Complete recovery can be very difficult to achieve, and few actually do. However, around 40% of cases can achieve periods of remission lasting as long as a year.
With support, medication, and therapy, many people with schizophrenia are able to function independently and live satisfying lives.